Everybody, and welcome to the Fatty Liver Disease webinar, a metabolic and naturopathic perspective. Now, this is part of our 2026 webinar series, which is a series of practitioner webinars designed to give you the tools to deal with a wide range of people in clinic. Now, before we begin, I just want to go through a few housekeeping rules. So these are practitioner webinars and are designed for practitioners and students of nutrition, health, natural medicine only. So if you are not one of these people, please do leave this webinar. You can ask questions as we go along, so just add them to the chat box and we will get to them at the end. And also don't forget to regularly check out the DR.VEGAN's professional website. So we regularly update it with the latest information, handouts, professional guidance, and of course, on-demand webinars. And we also have brand new abstracts available on the professional's website, and these are excellent resources for you to check out, so please go and do that. And of course, if you haven't already done so, please do sign up to the practitioner scheme. You can get discounts, commissions, free products, and we also have professional guides where you can find all of the research drug-nutrient interactions of our products as well, so really handy to have those in clinic. We also have a great opportunity for practitioners at the moment. You can review a formula of a product in your professional capacity, so you can give your opinion on the formulation. And as a thank you, you will receive that free product. So it's a really great way to try lots of our different products, and you can do as many as you like. So do check that out also. Okay, so today, we're your hosts, so that's myself, I'm Ella, and Mark. And I am actually the practitioner lead at DR.VEGAN, and I try to ensure that practitioners have the resources that they need necessary to deal with clients. And every month I get the best experts in to come and give you some great insights into topics of their expertise. So Mark, do you want to introduce yourself, tell everybody a little bit about you?
Yes, thank you very much, Ella. Thank you for the introduction. Yes, so I'm Mark Killick. So I'm speaking tonight. I see from that bio there, I'm senior lecturer at CNM. So I don't know whether that means that I'm old or I've just been there a long time. But yeah, so but I enjoy teaching there. I've also a registered functional nutritionist with a strong emphasis on metabolic health and men's health. So I'm really delighted to be speaking about this particular subject tonight, and I think you'll be fascinated as to how prevalent it is amongst the clients that you see, and probably clients that you see that don't even know that they're suffering with fatty liver. So yeah, looking forward to the journey and also the clinical aspect of it. So I'm going to make an emphasis on that for you tonight, so you'll be able to take a lot of take homes into practice itself.
Fabulous, thanks for that, Mark. Okay, so today we're going to be discussing basically everything fatty liver disease. So we're going to be looking at the liver, the control of metabolic function, and NAFLD overview. We're going to be looking at the pathophysiology, insulin resistance, adipose overflow, and DNI. We're going to be looking at fructose, alcohol, and the gut-liver axis. Mark's also going to be looking at things like fasting, ketogenesis, carbohydrate restriction. We're also going to be looking at diagnosis, so both conventional and functional assessment, fibrosis staging and non-invasive tools, naturopathic and dietary interventions, and also we're going to have a look at a couple of DR.VEGAN supplements, so detox and debloat, choline and vegan omega-3, so we can see how those can fit into our clinic as well. Okay, so without further ado, let's get going. Over to you, Mark.
Okay, thank you very much. So next slide. So the first thing I want to talk about is sort of like why it matters. You know, what was the burden to people around the world? So we're going to go into that in a little bit more detail. But the first thing I want to talk about is the name itself, because it's sort of clinically important how this name's developed, because for years it was described as non-alcoholic fatty liver disease. So that was a real clinical problem, because the people that were sort of actually diagnosed with it were actually sort of thought, well, actually, you know, what's the problem with alcohol? So the result was that people sort of were told, people who didn't drink were told that they had fatty liver, and they didn't really know the reason why they actually had this fatty liver. And also implied that it was sort of a milder, less serious version of the rather than fatty liver caused by alcohol consumption. So there was an international consensus about changing the name, and it was formally replaced with MASLD, which is metabolic dysfunction associated steatotic liver disease. I know it's a bit of a mouthful, but every word in that has meaning. So we pushed it into being a metabolic condition, sort of. And so straight away we're talking about things like hyperinsulinemia and sort of like overconsumption of carbohydrates. So steatotic, that describes the pathological findings, so the fact that the actual liver is fatty itself. So now we've got a sort of proper definition, so it actually sort of sits in its own right away from the sort of alcoholic version of the actual particular disease. But it doesn't mean that alcohol is still not a driver of this, and we'll come on to that later. So this is whereby it's very relevant to you as practitioners, whereby, you know, look at your clients, and if you actually see that you see something that's metabolic with your clients, always look to the liver. It's, you know, so we want to be assessing things like insulin, looking at triglycerides, looking for metabolic syndrome, because these are all very important as far as this condition's concerned. So this new reframing means that we can actually deal with this in a correct way. So when you explain to a client that their liver condition has a metabolic cause, that it's driven by insulin and carbohydrate metabolism, but not by some mysterious process or moral failing, you know, the therapeutic conversations, they change completely. So that's the gift of this new name. So let's look at the scale of the problem itself. So we got 1.5 billion people worldwide actually sort of like suffer with fatty liver disease, and the prevalence has nearly doubled since 2005. So and it's sort of there's a sort of a lockstep alongside obesity and type 2 diabetes. So you can see these comorbidities that we've actually got here as well. So metabolic syndrome, type 2 diabetes, but also we can look at problems with PCOS, sleep apnea, hypertension, hypothyroidism. These are all very intertwined as well. When we have these, when we look at high risk groups, so 38% of people with type 2 diabetes also have fatty liver, 3 times the general population rate, and 51% of MASLD patients are obese, and 43% meet the criteria for metabolic syndrome. So and it brings about a greater risk of sort of hepatic cancer as well. So you know, if you're not checking routinely sort of fasting insulin, liver enzymes, you know, this is what we should be actually doing with our clients, especially if you do see elevated liver enzymes. You know, we ought to be thinking about the reasons for that. So if we get into the sort of the pathophysiology of the actual condition, which is the next slide, please. So if I can have it up. Yeah, so here what we're going to look at the different aspects of the condition. So insulin resistance, this should be at the forefront of our minds when we're thinking about fatty liver. Adipose overflow. So this is a very interesting. This is when the fat cells, they've reached their sort of their fullness, and they can no longer accept fats within the fat cell itself. So they actually start to spill out fatty acids, and these fatty acids, free fatty acids in the blood, and they're taken up by the liver itself. And then we got the de novo lipogenesis that actually takes place within the liver. So we're going to talk about that. And then the last aspect, which is a sort of the underestimated aspect of fatty liver, but it's something that you as practitioners are often very aware about, the part that the gut plays within any sort of a systemic sort of inflammatory condition. So we're going to look into that a little bit more. So if we move on to the next slide, we're going to look at this metabolic spectrum. So this disease progression, this sort of like metabolic spectrum that we've got. So it sits on the spectrum, and it's where a patient sits on it determines the urgency of your interventions and also what's achievable. So you can see we can pass through different stages of the disease, from simple steatosis, where we've got fat buildup within the liver, right through to cirrhosis, you know, sort of like, and it depends at what stage the client is or the patient is as to how effective our interventions are going to be. So at the mild end, you know, simple steatosis, more than 5% of the liver by weight is fat. But there's no inflammation at this stage and no structural damage. So this is completely reversible at this particular stage. So this is your intervention window. As we move along the spectrum, the fat accumulation starts to begin triggering inflammation. So this is the second stage. So that's MASH, the metabolic associated steatohepatitis. So hepatitis, inflammation within the liver cells. So at this stage, we've now started to get active hepatocyte injury. So injury to the cells themselves. And when it continues further, the liver starts to lay down collagen, and we get fibrosis starting to take place. And this is measured on a sort of spectrum through F1 through to F3. When we get to F4, that's when it sort of is cirrhosis. So this is when we got irreversible structural damage, and that's when we get this dramatically elevated cancer risk. So this is the sort of clinical insight that I want you to remember, because it's about only about 5% of people with a simple steatosis will progress to cirrhosis. So you think of the implication that has. If you've got 1.5 billion people worldwide with fatty liver, and 5% of those 1.5 billion are going to progress to cirrhosis, you've got a real big health problem there. So this is where we look at the first stage as our intervention window, and this is where naturopathic medicine is very, very powerful, you know, in sort of like reversing the condition. I'm going to show you exactly how to use that. So what drives fat into the liver? So actually everything comes back to insulin. So if I can have you have the next slide, please, Ella. So next slide, please, Ella.
Oh, is it not come up on the screen?
Oh, it has now. Yeah, that's great. So yeah, so when we talk about insulin resistance, there's a sort of two-part pathology that's driving this fatty liver. So we've got the impaired insulin action, which is the first part, and then we got hyperinsulinemia, which is the second part. Although we can sort of divide them into two parts, they're pretty inseparable as far as the actual disease is concerned. So the first thing we got is where certain cells stop responding adequately to insulin signals. So that doesn't happen everywhere at once. You know, it happens, it sort of starts to happen within skeletal muscle. And so we get an increase in blood sugar. And with that, we then get that progressing to the fat cells. So what happens within the fat cells when they stop responding to when they stop responding to insulin, it's usually when they're full of fat. So we have a certain number of fat cells. This is quite an interesting sort of like sidebar, if you like, you know, sort of like we actually develop a number of fat cells as we grow to puberty. Once we go through puberty, usually that number of fat cells is set. So we don't actually sort of start to grow more fat cells, but the fat cells we have if we start to lay down a lot of fat within the cell, will sort of suddenly grow and grow and grow until they can't take up any more fat within the cell. At this particular stage, they start to lose fatty acids into the actual bloodstream, and that pushes back to the liver, where they actually then start to lay down as fat within the hepatocytes. So this is what I was referring to, is that fat overflow that starts to take place. And then we have this hyperinsulinemia. So this is the chronically elevated blood insulin. And here's the single most important mechanistic point of the whole evening. Insulin resistance and hyperinsulinemia are inseparably linked. So you can't have one without the other. And the fundamental truth that follows from that is the liver cannot store fat unless insulin is elevated. So insulin is the enabling signal. It activates the fat manufacturing enzyme, and it blocks the liver's ability to export fat via the very low density lipoprotein particles. So this is why the fat will then accumulate within the actual cell itself. So this is the perfect storm that's being created by this insulin resistance, and then this increased output of insulin. So if you take nothing away from tonight, is if we can control insulin, it's the most powerful intervention that we can bring for fatty liver disease. So this is why I'm going to be talking about lower carbohydrates, intermittent fasting. So this is where you're very, very powerful with diet, lifestyle, and supplements to bring about resolution to this particular pathology. Yeah, so if I can have the next slide. Yeah, so now we're going to talk about sort of the sources of hepatic fat in fatty liver disease. So if we look at this paper here, so this is by Donnelly et al. This was in 2005, and what they did is they used stable isotope tracing to directly measure the origin of fat in sort of the non-alcoholic fatty liver disease patients' livers. So what they found was that 59% came from circulating free fatty acids. So this was the overflow of fatty acids from the fat cells that have become very full with fat themselves. So this is insulin resistant adipose tissue that was pouring out fat. And then 26% came from the de novo lipogenesis that takes place within the actual liver. So the liver, that's the liver synthesizing new fat from carbohydrates. Only 15% came from the chylomicron, so the dietary fat that we actually absorbed within the actual digestive system. So that means telling a patient with fatty liver to eat a low-fat diet only addresses 15% of the problem at absolute best. So this is where there was another study which was by Lambert in 2014, and it found that the non-alcoholic fatty liver disease patients have a 3 times higher ratio of de novo lipogenesis than the healthy controls. So their livers are in fat manufacturing overdrive, and the fuel for that process is carbohydrates, so sort of non-dietary fat. So you can see that a lot of the advice to patients that suffer with this particular condition is to eat less fat. But you know, we don't get the advice to eat less carbohydrate, and I'm going to sort of like make the case for you this evening that would be something to do to bring about resolution to this. So when patients ask if they have fatty liver disease when they barely eat any fat, this slide's your answer. The fat is being made internally from carbohydrates driven by the insulin. So dietary fat is almost besides the point. So let's look at 2 actual specific compounds that actually relate very much to liver, if I can see in the next slide as well, so this is fructose and alcohol. So So these are also independent hepatotoxic drivers. So besides the fact that insulin resistance is pushing fat from fat cells to the actual liver, and also insulin is creating the de novo lipogenesis, we also have fructose and alcohol that can actually be adding to the problem. They don't require the standard carbohydrate insulin pathway to cause hepatic damage. They hit the liver directly through distinct mechanisms. So the one thing about fructose, and when we look at where we get fructose from, so most people's intake of fructose would actually come probably from their intake of refined sugar. But also bear in mind, with also some people, sort of still think that drinking fruit juices is very, very a healthy part of their diet. And when you think of fruit juice, it's basically fructose. We got to bear that in our mind. So fructose, unlike glucose, glucose is sort of like metabolized by virtually every cell in the body, but fructose is almost exclusively processed in the liver. So that entire metabolic burden will just land in one place, the liver. So when it arrives, it bypasses the glycogen saturation signal that would normally slow down glucose processing. It drives de novo lipogenesis directly because the liver has to do something with that fructose, and it sort of like turns it into fat. Every molecule metabolized generates uric acid. There's a specific mechanism for that. We know where, which you can always go into, but it's uric acid is independently inflammatory. If ever someone with uric acid crystals in their toe, you know what an inflammatory condition that is. There was a study by Lee and his colleagues, and it showed a significant increase in hepatic de novo lipogenesis within just 7 days of a high fructose diet. So the clinical message there for your clients is fruit juice is among the most hepatotoxic things a patient can consume habitually, and encourage them to eat fruit, not drink it. So high fructose corn syrup, also in processed foods, need to go there. That's more of a problem in the US than it is within the UK, but also put refined sugar into that process as well. So when we got refined sugar, we got a balance of glucose and fructose within the sucrose molecule. So alcohol, let's talk about that. So that operates through 3 simultaneous mechanisms. First, the actual metabolism of ethanol within the liver by alcohol dehydrogenase. What that does, it actually shifts the NAD plus to NADH ratio, and this then inhibits beta oxidation, so that we can no longer burn the fat. So like it's actually, instead we're storing the fat. So it's another way in which we store the fat. Also, ethanol itself directly activates fatty acid synthase, which is the key enzyme in de novo lipogenesis. So we're not able to burn fat, we start to store more fat within the liver itself. So alcohol drives that fat synthesis even without any carbohydrate. So, and then third, and this directly connects to choline, which we'll be talking about as an intervention later on down the road. It inhibits very low density lipoprotein assembly. So this means that fat cannot now leave the liver. It's trapped within the liver. And the last thing is, because most alcoholic drinks will contain sugar as well, once again we have the fructose from the sugar, which is going to add to the process as well. So So if there's 2 changes, once again, you can make with your clients, you know, to get a really early investment, is to actually eliminate fruit juice, you know, so, and also eliminate or drastically reduce alcohol. It's one of those things, actually, we often say reduce it, you know, but actually, you know, eliminate it, you know, so like it's, you know, you'll find that you get results far quicker, and you get a really meaningful shift in the way in which the liver will build up fat. So if I can move on again, I think I just got to talk about the gut liver axis as well. Yeah, so this is quite critical as well. So this is and what's happening here is we look at the diets of our patients, and we see this a lot with people, whereby if we have a lot of sugar, alcohol, ultra-processed foods within the diet, this is going to shift the actual microbiome quite significantly. You know, we're going to get an increase in Firmicutes and sort of a decrease in the more protective Bacteroidetes as far as the actual intestinal or the mucosal layers concerned. So because of that sort of diet creating a sort of dysbiosis, we then end up with sort of like an increase in the intestinal permeability, so leaky gut. And this is where we actually then get the leakage of LPSs, lipopolysaccharides from the gram-negative bacteria into circulation, which increases systemic inflammation throughout the body, and especially within the liver as well. Because remember that the first bypass will be the portal vein, which then takes the lipopolysaccharide directly to the liver. So this is why we get an increase in inflammation, and this is via the toll-like receptor 4, which then increases NF-kappa B, the transcription factor for inflammation, therefore producing the inflammatory cytokines interleukin-6 and TNF-alpha. So we get a lot of inflammation starting to take place. And remember, when we get inflammation, we start to get damage, you know, so we can get more scarring of the actual tissue here. So we, you know, straight away we can have naturopathic interventions here, where we can use probiotics, so Lactobacillus bifidobacterium, which will then sort of help the mucosal layer. We can use prebiotic fibers, sort of things like inulin and phos, but also at the same time removing the unhelpful parts of the diet, so the high sugars, the alcohols, etc. Stimulating bile as well, so using herbs, which we'll talk about later when we come on to the actual supplements, so we can stimulate flow of waste from the actual liver itself. So if I can now talk about the diagnosis, so if we can move on to the next slide, please, Ellen. Yeah, so we actually, although we often think about the diagnosis within the allopathic world, there's certain things that we can look at in blood tests that can actually help with the diagnosis, even within our clinic. So if we go to the next slide, I'll work through those. So yeah, so there's a conventional and functional assessment that we can actually look at. So we often do look at blood tests, you know, so we run, a lot of us run a lot of blood tests within our clinic, or we see blood tests that have been run by the GP. So we can look at some liver enzymes. We can look at sort of things like ALT, alanine aminotransferase, and AST, aspartate aminotransferase. And if we start to see raised levels of these, you know, it can mean that it's pointing towards some kind of liver damage, because these are now being leaked out hepatocytes themselves, which may in turn push us towards pressing our clients to go and have some imaging done, some ultrasound, to actually look at the liver itself, to see whether there's anything shows up as far as fat build up within the liver itself. But there's certain other enzymes. We can look at GGT as well. We can also look at fasting lipids. One of the ones we do look at is HDL cholesterol. If we start to see it decline, it can correlate a lot with liver disease. The ratio of ALT to AST is one of the most clinically useful numbers. So a ratio of greater than 1 moving towards 2 points towards fatty liver disease. The one thing about that, also ALT and AST are expressed in muscle tissue as well. So if we got strenuous exercise, we can have leakage. So if you are working with a client, make sure that there's been no strenuous exercise 24 hours to 48 hours before sort of like interpreting the test. But one of the things that sort of like should be the takeaway is actually measuring fasting insulin. It's something that we don't do enough of. It is a difficult test to run. Sort of like I've done a lot of work here as to what will give us an accurate fasting insulin result. The best way would be to intervene an intravenous sample, but that then has to be centrifuged and pretty much frozen before you send it away. Otherwise, we can get because insulin is a sort of peptide, it can start to degrade through proteolytic enzymes. However, there are some blood spot testing which has decent accuracy to measure fasting insulin. So going back to what I was saying, that as insulin is a main driver, knowing fasting insulin will actually be able to push us into numbers where we can actually see whether we've got a situation we've got hyperinsulinemia. Our functional target is 6 micro-international units per milliliter or below. This is where we want to look, but 7 to 17 is a warning zone, and above 17 is hyperinsulinemia. So this is something we can run with our clients, and you can see as we go through the imaging, we can start to see sort of fibrosis and also the biopsy. That would obviously be in the allopathic world to look at that, but that's as if advanced fibrosis is actually suspected. If you go on to the next slide, I can see how we can develop the figures even more. So this is where we actually look at the fibrosis staging. So this is known as the Metavir score. So once we suspect or confirm MASLD, we want to see how advanced it is. So the score runs from F0 up to F4, where F4 is sort of cirrhosis. So you can see here, it's been colored whereby, when we have fibrosis at stages of F0 to F2, this is where we can still make meaningful intervention. When we're at stages F3 to F4, this is where it's getting where we need co-management with the allopathic world, and especially when we get towards cirrhosis. So we can actually stage our patients without a biopsy. So we look at something called the FIB-4 score. And it's derived from 4 values already on our routine blood panel. So that's the age of the patient, the AST value, the ALT value, and also the platelet score. There is a formula. You can always ask me, email me or whatever for this formula, but it's actually the age multiplied by AST divided by platelets multiplied by the square root of ALT, and that will give you a score that we can actually work out the fibrosis. So below 1.3 is low fibrosis risk, and that's a green light for our naturopathic protocol. Above 2.67 is high risk, and that's when we refer our clients. So you can see I'm trying to sort of build a picture where you've actually got a lot of tools in your toolbox to actually help clients with fatty liver disease. And remember, there's many of them out there. So let's look at the pharmaceutical landscape. So if we go on to the next slide, just to see what's happening in the allopathic world as far as management's concerned. Yeah, so this is interesting because There's different pharmaceutical approaches, and some of them are actually quite novel at the moment. So especially, you know, when we look at sort of like the second two, the GLP-1 agonists and the drug which is resmetirom. They're quite new kids on the block, but originally sort of like there were no specific licensed drugs for fatty liver, and lifestyle modification was the first line. Not because there was strong evidence, but because nothing else really existed. So the first one is the PPAR gamma agonists, and the main one is something called pioglitazone, and that's one of the I can never say this word, but I'm going to have a go. Thiazolidinine class of drugs. These are drugs that are used to treat type 2 diabetes. You know, so that what they do, they work by promoting fat cell proliferation, so it creates smaller adipocytes, each one being more insulin sensitive. You know, so it means that we can promote the storage of fatty acids away from the liver, and it makes sort of like it just makes the body a little bit more insulin sensitive. So there was a study in the New England Journal of Medicine by Belfort in 2006, and it confirmed improvements in liver histology. There are downsides to this: weight gain, fluid retention, and increased fracture risk in women. Then we can talk about the GLP-1 agonist, so semaglutide. Who's not talking about it at the moment? But it's being the most studied. It's generating quite a lot of excitement. There's the phase 2 trials showed a 59% fatty liver resolution versus a 17% on placebo. It's one of the thoughts. I mean, so I heard this the other day, and so you know, it's almost like, don't quote me on it, but we're talking a lot to our clients about how, you know, sort of like semaglutide, GLP-1 sort of loses a lot of lean body mass, you know, rather than fat mass from the body. But it could be that actually what we are losing a lot of is actually liver fat, and this shows up the same way as far as lean body mass. So it's a lot. I think this is where the GLP-1 agonist could be, you know, quite useful for this particular condition. But obviously we do know the we do know the downsides to this. They do carry the gastrointestinal side effects. They also are expensive. You know, I think this is the thing. You know, everyone thinks that GLP-1's for everyone at the moment, but actually they will be a considerable burden to the health service if they were actually given to everyone. But the new one that we've got at the moment is this resmetirom. It's the first drug that's specifically FDA approved for fatty liver with fibrosis. It was only approved in the UK this June. So it's a thyroid hormone receptor beta agonist. It acts directly in the liver to reduce lipid synthesis and fibrosis markers. So yeah, fibrosis improved by at least one stage in 26% of patients. So that's, you know, when you're talking about this, the fibrosis staging, that's very, very relevant. But one thing to say, and it's probably true about most pharmaceutical intervention, is once again we're not looking at the underlying cause here. What's driving this fat deposit within the liver itself? And this is where we come in as sort of like as naturopathic or functional medicine practitioners, because we're going to be looking at the metabolic root cause. And so this is where I'm going to now concentrate the rest of the presentation, is looking at how we can actually intervene. So I can have the next slide, please, Ella. So this is where we're going to look at dietary intervention. So this is the naturopathic and functional medicine approach: dietary intervention, fasting, exercise, and also broader lifestyle optimization. So this is where our clinical practice meets the pathophysiology that we've actually built up. So you can understand why we're going to be making these interventions. So if I can have the next slide, please. So right, dietary intervention, what are we talking about? So this directly sort of like is a result of the pathophysiology. So if we look at insulin being a major driver, what pushes insulin in the body? Well, we know that glucose produces insulin in the body. So this is why, you know, we want to try and reduce insulin. The one way to reduce that is to reduce the carbohydrate intake, you know, so like the starchy carbohydrates, the sugars, etc. This is what drives insulin. So this is lower insulin is the fastest dietary route to actually reduce liver fat. So we can actually see reductions in liver fat very, very quickly if we take away the carbohydrate. So if we reduce carbohydrate, reduces post-meal insulin peaks, lowers insulin means, and that, I mean, lower insulin means we have less de novo lipogenesis. So we have less suppression of the very low density lipoprotein export. So we have, and also we have less fat cell overflow, you know, the overflow from the fat cells. So the liver starts to begin to clear. And also the evidence for this is really consistent and compelling. There was a study by Browning in 2011, and he found that 58% of liver fat reduction in 14 days on a very low carbohydrate diet versus 28% on a low calorie diet. And the reduction occurred before significant weight loss. So that's an interesting one. You know, it's not that people will see weight loss. And there was another study where insulin lowering was the mediator, not calorie deficit. So they kept calories the same, they just lowered the carbohydrates. And this was a trial by Holmer in 2021, and 57% reduction on an isocaloric low carb diet. So isocaloric means it's the same calories. So just different macronutrients brought about this resolution. And this was confirmed by another study by Joe Hansen. Carbohydrate restriction outperforms fat restriction for liver fat reduction, even when total energy is matched. So this is where we use an intervention like a Mediterranean style low carbohydrate approach, olive oil, olive fish, vegetables, nuts, legumes, with carbohydrates coming from vegetables and berries rather than bread, pasta and processed foods. So a lot of evidence there. And also when we have time restricted feeding or intermittent fasting, this amplifies the benefit. So a 16-8 eating window extends the overnight insulin trough and promotes a daily period of fat oxidation and ketogenesis. So it gives the liver a regular opportunity to clear that accumulated fat. So liver fat falls measurably, you know, in the presence of that. So that's the key principle there, is insulin reduction, not caloric restriction. So when we frame this for our patients, we're not removing fats from your diet, we're removing the signal that tells your liver to manufacture fat from scratch. This is the really important part of the intervention. If I can have the next slide. It's just because it's not just about it's just not about the diet. We can also bring lifestyle into this. So resistant training, you know, sort of like it's underestimated in this particular case. What it does is it increases the glucose transporter translocation into the membrane, so we get more glucose uptake by the actual muscle cells, and therefore it increases our insulin sensitivity. It reduces that systemic insulin demand, and therefore it reduces the hepatic fat storage signal. Another study in 2013 showed 34% liver fat reduction from resistance training alone, independent of weight loss. Aerobic exercise as well, so you can have a combination of the two. It increases hepatic fatty acid oxidation directly. So 150 minutes of per week, moderate intensity, produces measurable, consistent liver fat reductions. So once again confirmed in another meta-analysis. Sleep, underappreciated. Short sleep elevates cortisol, and ghrelin drives carbohydrate cravings, worsens insulin resistance. So this is where you might see a correlation between sleep apnea in your patients that are suffering with fatty liver. It's very common in this particular population. So this is where, doing your work on your consultations, you can ask these questions as to what's happening with the client itself. Also, the HPA axis matters, so this is it drives that hepatic gluconeogenesis, so the production of new glucose will promote the central adiposity, visceral fat laying down. So once again, this is where we can use adaptogenic support for cortisol production. We can also use stress reduction techniques with our clients as well. So seed oil reduction, there's no doubt that sort of like the omega-6s increase inflammation, mitochondrial dysfunction, and therefore decrease fat oxidation within the fat, so we get more fat accumulation. So once again, this is where another intervention, omega-3 fatty acids, can be particularly important as far as the interventions concern. So if it can take me on to the next slide, and I can I think I start this. So if we look at the supplements that DR.VEGAN have that can help with the condition. So using glucobalance, detox and debloat, choline, also other ones that aren't here, even the gut works with the probiotics and also the vegan omega-3. These are two more that we can put in the mix with our clients. So if I go on to the next slide, just to show an overview of how they work all together. So it's glucobalance that sort of like targets the root problem, the insulin dysregulation. So everything described today comes back to elevated insulin. So glucobalance works across multiple points in the insulin glucose axis to reduce that signal. Berberine is a cornerstone ingredient. There was a trial in 2008 that showed berberine lowered fasting glucose to a comparable degree as metformin, and its mechanism is the AMPK activation, so the same cellular energy pathway that exercise and fasting activates. So it's a good signaling. Chromium, cofactor with the insulin receptor, and cinnamon extract blunts that post-meal glucose spike by slowing the gastric emptying and inhibiting carbohydrate digesting enzymes. So this is where we can see that we can see whereby we're approaching it from a different angle than, say, the GLP-1 agonists, but sort of that, and therefore it's a more sustainable protocol for our clients itself. Detox and debloat addresses what I think of as the liver's capacity under pressure. So the liver is dealing with excess palmitic acid. It's a 16 carbon fatty acid that the liver will make in de novo lipogenesis, and that's directly pro-inflammatory. And if we got that with LPS from a dysbiotic gut, compromised phase 1, phase 2 detoxification. So this formula will support the liver's ability to handle that burden and protect itself during that metabolic recovery process. And it helps promote our bile flow as well, which is important. And choline enables the fat that's been processed to actually leave the liver. So without phosphatidylcholine, it cannot assemble the very low density lipoprotein particles, and that is what we need for that triglyceride support. So if we have no choline, we've got no VLDL, so we've got no fat export. So fat is trapped. So very much you've got to look at sort of like people's diets, so vegans and vegetarians might have very low intake of choline going forward. Next slide, actually. Next slide. So this is where yeah, I'm just going to shove this case study in. So this was a 44-year-old female, BMI of 31.2. She had desk-based work, and she was presenting with fatigue, and also she had dull right upper quadrant discomfort. So that's classic fatty liver. Persistent bloating, brain fog. And if you look at diet, you know, so high sugar, ultra processed food, daily fruit juice. Everyone thinks it's healthy. 10 units of alcohol per week. And when we look at her liver markers, ALT was very high, double the upper limit of normal, and she had an ALT to AST ratio of 1.55. So that was a flag for fatty liver disease. And also her fasting insulin was 19.2. So that was against our functional target of 6 or below. Triglycerides were also very high. And when we worked out her FIB4 risk, she had a 0.72. So she had low fibrosis risk. So that was mild to moderate steatosis. So that means that, you know, our intervention is very timely at this stage. So the 12-week naturopathic protocol was to eliminate the juice, the high fructose corn syrup, the alcohol, low carb, and put her on a low carb Mediterranean style diet that we spoke about before, and using sort of berries over tropical fruits. Putting her on a 16/8 time restricted eating, so so that was just delaying, you know, food till 10 a.m. rather, no food after 8. Also increasing her exercise, so what she could do, things like brisk walking, but also some resistance band work as well, building up her exercise as she went through it. But then the protocol on the supplements was the glucobalance, 2 caps with lunch and dinner, detox and bloat, 1 cap before each meal, and choline 500 grams with breakfast and dinner. And then we actually sort of like saw that mechanism then brought down her actual sort of markers. Her liver markers reduced, her fasting insulin reduced, and we could see that we actually sort of reversing the actual fatty liver disease. If I have the next slide, please. Yeah, so there is sort of like things that we must sort of build in. So you know, we're most powerful in the early stages, sort of like the F0 to F2. Where the disease is really metabolically driven, generally reversible. It's essential to be clear about when we refer. So if the ALT or AST is more than 5 times higher, the upper limit or normal, that's not straightforward fatty liver. And also any signs of cirrhosis, or like jaundice, sort of malfunction of the brain, sort of you know, so this needs an urgent sort of like hepatic review. Also, if we end up with a FIB4 score above 2.67, or they come back with a FibroScan above 12.5, high probability of advanced fibrosis, so then we refer as well. Any unexplained weight loss, you know, it could be that they need to be screened for something a little bit more ominous, you know, sort of carcinomas, or maybe some kind of viral hepatitis or autoimmune hepatitis. So that's when we need specialist support. But the key markers that we'll be looking for is a fasting insulin after our intervention of lower than 6. The HOMAR score, I haven't got into that. Triglycerides less than 1, and also the ALT to AST ratio of less than 1. So, and now I'm going to hand over to Ella. I'm really conscious about time. I'm so sorry.
No worries, Mark. Thank you so much for going through that. It was really, really interesting. I'm going to quickly talk you through another couple of supplements in much more detail. So the first one we have is debloat and detox. And as you can see here, it's fully comprehensive, and it supports both the liver and the digestive health. So it really helps to support that bile production, as well as providing those herbs and nutrition that's required by the liver, and various, supportive herbs to help to normalize kind of fatty liver disease or anything that's kind of metabolically wrong within the liver. Okay, so we have in here, so we've got the milk thistle seed powder and also the seed extract as well. We've got the fennel seed, dandelion root, artichoke, sandra berry, burdock root, as well as glutamine. So it is a full package there. So we do have the milk thistle as the first ingredient, and the active there is silymarum. And silymarum has been shown to decrease liver enzymes. So that's ALT and AST. And when these are high, these indicate damage and distress to the liver cells. MASLD is the most common cause of elevated liver enzymes. So the fact that silymarum can reduce those enzymes, that's a really good indication of liver health. So next we have fennel seeds. So these are highly antioxidant and anti-inflammatory. They contain anethol and other flavonoids. And these reduce the oxidative damage, reduce the inflammation, and of course, inflammation, oxidation are drivers for fatty liver disease progression. So helping to calm everything down, bring everything down a notch, really helps support the healing of the liver. Okay, so we also have dandelion in here as well. And dandelion helps fatty liver disease because it contains things like antioxidants as well as plant compounds, which also reduce liver inflammation and oxidative stress. And also animals studies suggest that it can help lower fat buildup in the liver and also support bile flow. So it goes back earlier when Mark was mentioning that having good bile flow is really important for liver health as well. So you're supporting those two areas with the dandelion as well. And we have our artichoke there as well. So artichoke, again, really helpful for fatty liver disease. Again, because it contains antioxidants and anti-inflammatory compounds. Also helps to support liver fat metabolism. And there are some studies that suggest that artichoke leaf improves liver enzymes, cholesterol levels, and also reduces the fat accumulation in the liver. So we also have in here Sandra. And again, that helps fatty liver disease because it's antioxidant levels, it's anti-inflammatory. And also studies suggest that it does reduce liver oxidative stress, improve the liver enzyme levels, and supports the liver's natural detoxification pathways. And we have burdock as well. Again, so burdock is a really great one for people to live with fatty liver disease. Again, because it's got the antioxidants in there, it's got the phenolic compounds, the lignans, and these all reduce oxidative stress and inflammation in the liver. And again, there's some animal studies and also some lab studies to suggest that it does support fat metabolism in the liver, and also can help protect liver cells from damage. So that's a really nice one to add in there. Okay, and finally we have glutamine. And there is some gut involvement in liver diseases and in the gut. There's that connection there. So reducing the inflammation that's coming from the gut has a really huge impact on overall inflammation and also liver inflammation. Also helps to improve the gut barrier function, which indirectly supports systemic inflammation. Okay, so we have another couple of supplements here, which I'm going to go through really quickly. So choline, Mark mentioned choline earlier. Choline is part of the B vitamin family, and it is needed for the cell mitochondrial membrane. And research has actually demonstrated that low dietary intake of choline is associated with fatty liver disease, because choline deficiency alters the mitochondrial membranes and can also lead to mitochondrial dysfunction, which is one of the causes of fatty liver diseases. And also we've got our vegan omega-3. So several clinical trials and meta-analysis show that omega-3 supplementation can significantly reduce liver fat content and blood triglycerides in people with fatty liver. So they may also help to reduce liver fat by lowering triglyceride production and improving fat metabolism, and that can directly decrease hepatic fat accumulation. Okay, so thank you everyone for staying on, and we hope you've learned a lot today. We've got time for some questions now. So let's just have a look to see what people have asked. Bear with me a second. Okay. So, Mark, should patients with NAFLD avoid all dietary fat?
No. I think that study. I think it was Donnelly data that said that only 15% of hepatic fat comes from the diet. So the problem is the carbohydrates. So no, it's actually as part of our naturopathic protocol, it will be the actual Mediterranean style low carbohydrate diet that will bring about resolution. So no, please eat your fat. It's got the strongest evidence. Yeah.
Okay. Okay, so another one here. Can patients with NAFLD eat fruit?
Yes, they can eat fruit, you know, so like, but it's the form that matters, you know. So I would strongly suggest that it's interesting, you know, it's that, I mean, I'm sure you've heard this before, you know, try and eat 5 apples, you probably wouldn't be able to do it, you know, but actually sort of juice 5 apples and you'd actually gulp that fruit juice down like there was no, you know, it was like a thimble full. So yes, please eat fruit because it comes with a lot of fiber that can actually help the actual gut itself. And I would switch to the sort of berries probably more than anything else because they actually are the lowest in fructose and they actually have the polyphenols that help with the gut liver axis as well.
Perfect. And just another one here for you, Mark. So when should we kind of refer patients on rather than naturopathic protocols?
Yeah, I think looking at those sort of red flags I did in the last slide. So when you get liver enzymes that are very high, sort of 5 times more the upper limit, and also if you do that sort of FIB4 score, and if you find a score more than 2.67, you know, that's when you would actually refer them to as well. Also looking at sort of like symptoms such as you know, sort of maybe sort of some brain inflammation or whatever, sort of jaundice, those sorts of things as well. You would refer those on as well.
Okay, and we have another question here for Julie Watson. I guess I'll take this one. Maybe I'll have your second opinion from you as well, Mark. She's saying, can you take detox and debloat supplements to support a person with autoimmune condition that attacks the bile ducts, causing scarring in the liver? I would initially say before doing this, kind of have to do a lot of work on the immune system to kind of rebalance that, sort the immune system out, stopping it from attacking the liver and the bile ducts in the first place. You know, look at vitamin D levels, look at repairing the leaky gut, look at repopulating with the gut microbiome. Certainly do a lot of dietary protocols that are going to support the liver, you know, things like high omega-3, anti-inflammatory, low fruit, low carbohydrates. Before looking at any of that, also potentially I would use some like systemic enzymes to help break down some of the scarring, and certainly the dietary interventions that Mark mentioned in this protocol. And I think if you did use detox and debloat, you'd have to start very slowly and check how they were getting on with it regularly. So maybe start with half dose. That's what I would recommend. What about you, Mark? Do you think that somebody with an autoimmune disease against the bile ducts could take detox and debloat?
Yeah, I'd also look at, you know, sort of how they're digesting generally. So like, you know, have they got a fatty stool? You know, is there sort of evidence that maybe the bile's not flowing that well? You know, sort of, I think we got to look at the bigger picture there. But probably with that, I go with your sort of little bit of caution, and at the same time bring in the interventions that I spoke about as far as reducing insulin, which is the real driver of this. So.
Yeah. Okay, perfect. Hope that answers everyone's questions. So thank you so much, Mark. If anybody does have any further questions, do drop me an email. So my email is on the screen, ella@drvegan.com. I can certainly pass any questions on to Mark. So thank you for staying, and do join us for next month's webinar, which is on anxiety. So a really good one to listen into. Quite difficult at the moment. Anxiety levels have exploded in the last few years, so do join us for that. And again, thank you so much, Mark. And
thank you.
We'll see you in November for our men's health webinar.
Brilliant. All right, look forward to it. Okay, thank you very much.
Bye.
Bye, everyone. Bye. Okay.